Good morning, students. Sorry for the delay. There is some inconvenience about the timing. So today's class is Cyclophyllidean Cestodes. So objectives for the today's class: by the end of the class, you should be able to know causative agents, morphology, life cycle, pathogenesis, clinical features and complications, epidemiology, laboratory diagnosis, treatment and prevention. So cestodes are broadly classified under two orders: Pseudophyllidean cestodes and Cyclophyllidean cestodes. Today we will discuss about Cyclophyllidean cestodes. In that Cyclophyllidean cestodes, we have Tinea species, Echinococcus species, Aminolepis species. In that today we will discuss about Tinea species. Classification of Tinea. Tinea species are pathogenic to humans. They are classified into Tinea saginata and Tinea solium. Tinea saginata, common name is beef tapeworm. It causes intestinal tiniasis. Tinea solium, common name is pork tapeworm. It causes intestinal tiniasis and cysticercosis. Tinea species, in the Tinea saginata, definitive host is man, intermediate host is cattle. It mainly affects the intestine. It causes intestinal tiniasis. Tinea solium, definitive host is man, intermediate host can be pig or man. It causes intestinal tiniasis and also cysticercosis. Coming to the history and distribution of Tinea. Tinea saginata has been known as an intestinal parasite of man from very ancient times. In 1782, Goes differentiated Tinea saginata from the solium. And in 1861, Leuchard described its life cycle, and also he demonstrated that cattle serves as an intermediate host for the Tinea saginata. The name Tinea is derived from Greek word meaning tape or band. So previously the word Tinea was commonly used for most of the tapeworms, but now it is confined to only the species belong to the genus Tinea. Tinea saginata is worldwide in distribution, but the infection is not found in vegetarians, those who do not eat beef. But nowadays, you can also see in vegetarians because of the contamination of the food. And Tinea solium is also worldwide in distribution. Habitat. Adult worms of both the species reside in small intestine, most commonly in jejunum. The larval of Tinea solium resides in cystic lesions in muzzle, brain, and eyes. Coming to the morphology, it exists in three forms, that is adult worm, eggs, and larva. Coming to the adult worm, which is opalescent, white in color, and it is ribbon-like, dorsoventrally flattened and segmented. Adult worm measures about 5 to 10 meters in length in Tinea saginata, and it measures about 2 to 4 meters in length in Tinea solium. So, it mainly adult worm consists of three important parts: scolex, or you can also call it as a head or scolex, then the neck, and then strobila. It is also called as trunk or body. So you can see in the picture, these are the parts of the adult worm. This is the scolex and the neck region. These are the suckers and upper part showing the hooklets on rostrum and the strobila consisting of segments. Scolex is 1 to 2 millimeter in diameter and it is quadrate in cross section and it consists of 4 hemispherical suckers. These suckers will help in the attachment of the worm to the intestine. And then the neck and the strobila, which consists of the proglottids or segments. Segments may be immature, mature and gravid segments. So you can see after the neck, initially there will be immature segment. After that, you can see mature segment and then gravid segment. And as it goes down, initially these are small and narrow. When it comes to the mature, these are little bit broader and longer compared to immature segment. And gravid segments are more longer and broader compared to the mature segments. So this is the picture showing the scolex and the neck of the Tinea Sarginata and Tinea solium. Tinea Sarginata neck is long and narrow. In solium, neck is short, broad and also it is a thick. And scolex in Tinea Sarginata, scolex is large and quadrangular. It consists of 4 suckers. So you can see in the top, you can see 4 round structures at different angles. These suckers are helping the attachment of the worm to the intestine and these may be pigmented in Tinea Sarginata. There is no rostrum or hooklets in Tinea Sarginata. In Tinea solium, the scolex is small and globular and there are 4 suckers present but the suckers are non-pigmented. So you can see in the picture these are the 4 suckers and there's a rostrum with the 2 rows of hooklets. So you can see at the top end this is the rostrum with the 2 rows of hooklets. So hence it is also called as arm tapeworm. So Tinea Sarginata is called as unarmed tapeworm. Tinea solium is called as armed tapeworm. Coming to the strobila. So as I already mentioned, strobila consists of segments that is immature, mature and gravid segments. The segments are 1000 to 2000 in Tinea Sarginata, whereas it is less than 1000 segments in case of Tinea solium. Gravid segments are more longer than broader. In case of Tinea Sarginata, it is 4 times as long as it broad. In Tinea solium, it is twice as long as it is broad. These segments in the consist of male and female reproductive structures. The testes are numerous. It is about 300 to 400 testes in case of Tinea Sarginata. Testes are less in solium. It is 150 to 200. The gravid segments has the 15 to 30 lateral branches in Tinea Sarginata and 5 to 10 in Tinea solium. That is, lateral branches are less in solium. And also Tinea Sarginata has a prominent vaginal sphincter and is lacking the accessory ovarian lobe in case of Tinea Sarginata. When it comes to Tinea solium, the vaginal sphincter is absent and also there is a presence of accessory ovarian lobe in case of Tinea solium. And there is a common genital pore which opens on the lateral wall of the segments. And these gravid segments are expelled outside through the anal sphincters singly in case of Sarginata. In solium, it is expelled in the chines. And there is no uterine opening. So, eggs are expelled by rupture of the wall. Coming to the morphology of X. It is round or spherical in shape and measures about 30 to 40 micron meter. It consists of two coverings, that is thin hyaline embryonic membrane which is present outside and it disappears as soon as the egg enters outside the body. And inner embryophore which is radially striated and is yellow brown due to the bile staining. So you can see in the picture there is the outer thin hyaline membrane or eggshell. So next to that you can see the radially striated embryophore. So inside the embryophore there is a fully developed embryo. It is also called as oncosphere and it consists of 3 pair of hooklets. Hence it is called as hexacanth embryo. The eggs do not float in saturated salt solution. Eggs of both the species of Tinea are similar. You cannot differentiate that it is a Tinea Sarginata or Solium egg based on the morphology of eggs. Coming to the larva. Larva in Tinea, it is called as Cystic circus. In Tinea Sarginata, it is called as Cystic bovis. It is found in the cattle's muscles, not in the man. In Tinea solium, the larval form is called as Cystic. It is present in the muscles of the pig and also in the man. So this is the picture showing the larval form. It is small, 6 to 9 millimeter and round, grayish white. It is resembles like a bladder, so it is a bladder-like worm containing. So these cysts consist of invaginated scolex with hooklets in case of solium. In Sarginata, it is without hooklets. And the larval form is smaller in Sarginata, that is Cystic. It measures about 0.5 to 1.5 centimeter, spherical, yellowish white, and outer bladder-like sac filled with the vesicular fluid and inner chamber consisting of scolex with hooklets. Cystic bovis. The word cystic is derived from Greek word cystis meaning bladder and ketkos meaning tail. The larva Cystic bovis is infective stage for humans. It is ovoid, milky white, opalescent fluid filled vesicle measuring about 5 to 10 millimeter in diameter. It is found in the muscles of mastication, cardiac muscles, diaphragm and tongue of infected cattle. On visual inspection, these appears as a shiny dots in the infected beef. Cystic cellulosa, it is the larval form of Tinea solium and also infective form of the parasite. It can develop in various organs of pig as well as in man. It is a ovoid, opalescent, milky white, measuring about 8 to 10 millimeter in breadth and 5 millimeter in length. It remains viable for several months. Coming to the differences between the Tinea Sarginata and Tinea solium. The adult worm length Tinea Sarginata is longer compared to the solium. On an average, it measures about 4 to 6 meters. It can measure up to 10 meters also. Tinea solium measures about 2 to 4 meters. Coming to the head and scolex, it is a large and quadrangular in Sarginata, small and globular in solium. It consists of 4 suckers which are pigmented, but there is no rostrum and no hooklets. In case of solium, 4 suckers are present which are not pigmented but bears a rostrum with 2 rows of hooklets. So Tinea Sarginata is called as unarmed tapeworm. Tinea solium is called as armed tapeworm. Neck, which is longer in Sarginata and shorter in solium. Coming to the body, that is number of proglottids. It is 1000 to 2000 in Sarginata. It is about 800 to 1000 in solium. Uterus bears 15 to 20 lateral branches, which are more in Sarginata and less in solium. That is about 7 to 13 lateral branches. And lobes of ovary. There are 2 ovary, no accessory lobes in Sarginata. 3 to 2 lobes with an accessory lobes are present in the solium. Testes are numerous, that is 300 to 400 follicles, and solium it is 150 to 200 follicles. Vaginal sphincter is present in Sarginata, absent in solium. Expulsion of segments, it is expelled singly in feces in Sarginata. It is expelled in chains of 5 to 6 in solium. Coming to the life cycle of Tinea Sarginata, host, definitive host is man, intermediate host is cattle. Infective stage is Cystic bovis in man, eggs are infective in cattle. It consists of human cycle and the cattle cycle. So life cycle of Tinea Sarginata. So man acquires infection by the ingestion of undercooked beef containing Cystic bovis. So once after the ingestion, Scolex exvaginates. Usually it is present inside the larval form. So it exvaginates and anchors to the intestine with the help of the suckers. And then in the intestine, it develops into the adult form, mainly in the small intestine. After about 10 to 14 weeks, there will be a fertilization occurs and development of eggs in the development of embryo, that is exocanth embryo, and there is a passage of eggs in the feces. So these eggs are ingested by the cattle while grazing in the field. Oncosphere hatches out and it penetrates the intestine and it enters into the circulation. So in the circulation, it filters through the muscles where they get seeded in the skeletal muscles and develops into the Cystic bovis in the skeletal muscle. So again, from this, man gets the infection when he eats the undercooked beef containing Cystic bovis. Coming to the life cycle of Tinea solium. Host is the man and also the pigs. Infective stage is Cystic cellulose in man, eggs in the cattle. And it causes intestinal teniasis and cysticercosis. Man acquires the infection by ingestion of undercooked pork containing Cystic cellulose. So after the ingestion, Scolex exvaginates and anchors to the intestine where it develops into the adult form and there will be a fertilization and development of the embryo and the passage of eggs in the feces. So once it is passed in the feces, eggs are ingested by the pigs while grazing in the field. Then oncosphere hatches out and penetrates the intestine. Then it enters into the circulation and then where it filters through the muscle and develops into the Cystic in the muscle. Again, man gets the infection by ingestion of undercooked pork. But sometimes there may be internal auto-infection also. That is, eggs are propelled back by reverse peristalsis. It is thrown back into the stomach by reverse peristalsis. So that is through the internal auto-infection. So oncosphere hatches out and penetrates the intestine, and it develops into the cysticercus and then enters into the, either they get seeded in the CNS, eye or muscle. So in the man, it is a dead end. Cysticercus, development of cysticercus, it is a dead end. It does not undergo further development. Or sometimes there may be external auto-infection, that is XR ingested by himself by unhygienic personal habits. Then oncosphere hatches out in the intestine and gets seeded in the different organs. Or sometimes infection, external auto-infection occurs through the contaminated food or water with the eggs, then development of oncosphere, and then the cysticercus in the CNS, eyes and the muscle. Coming to the pathogenesis and clinical features. So it causes intestinal teniasis, which is caused by both Tinea sarginata and Solium. So most of the times patients are asymptomatic in spite of large worm inside the intestine. There will be a little bit of inconvenience in the patients, and there will be a passage of proglottids in their feces. And it can cause mild abdominal discomfort, indigestion, nausea, loss of appetite, change in the bowel habits. There may be a diarrhea, and occasionally it causes obstruction by migrating proglottids, and it mimics the appendicitis or cholangitis. Cysticercosis is caused by mainly Tinea, Solium. Any organ or tissue may be involved by cysticercus. Most commonly, it involves the subcutaneous tissues and the muscle. It can also involve eyes, brain, and less often heart, liver, lungs, abdominal cavity, and the spinal cord. Cysticercus is surrounded by a fibrous capsule, except in the eyes and ventricles of brain. The larva evoke the cellular reaction, starting with the infiltration of the neutrophils, eosinophils, lymphocytes, plasma cells, and at times giant cells. This is followed by fibrosis and death of the larva with eventual calcification. Clinical features mainly depends on the cyst location. In subcutaneous cysticercosis, it causes palpable nodules. In muscular cysticercosis, it causes the muscle pain and the weakness. Ocular cysticercosis, it causes proptosis, diplopia, and loss of vision. And if it it causes neurocysticercosis in the brain. Coming to the neurocysticercosis, it is the most common form. About 60 to 90% of cases of cysticercosis and parasitic CNS infection of the man, and also adult onset epilepsies throughout the world. There are most commonly two types. One is parenchymal and extra parenchymal. Parenchymal most commonly involves the brain parenchyma. Extra parenchymal sites are meninges, ventricles, and the spinal cord. Subarachnoid space is the most common site of involvement. It can be asymptomatic neurocysticercosis to the various manifestation. It causes the seizures in 70% of the cases, hydrocephalus, increased intracranial tension, chronic meningitis, focal neurological deficits, psychological disorders, and dementia. Clinical presentation is variable and depends on the number of cysts, location and size of the cyst, and morphological stage of the cyst, and also post-immune response. Coming to the epidemiology of cysticercosis in India, it is most common parasitic CNS infection of the man, and it is one of the most common cause of adult onset epilepsy. Recent studies with the CT and MRI suggest the burden in India is 18 to 31% in suspected cases of epilepsy. It is prevalent in various places like Bangalore, Delhi, Vellore, Bihar, Uttar Pradesh, Pondicherry, and Chandigarh. Coming to the laboratory diagnosis. For intestinal teniasis, stool examination. So what it detects? You can detect the X, and you can microscopic examination of the shows characteristic X of the tinea in 20 to 80% of the patients. Formal ether sedimentation method of the stool concentration is useful, and also you can detect by cellophane swab method in 85 to 95% of the patients. But by X you can't differentiate the species. Both the eggs appear similar. Species identification can be done by examining with the handheld lens the gravid proglottids which are pressed between the two slides and observe for the differences between the two Tinea, Sarginata and the solium. Definitive diagnosis can also be established by demonstration of the scolets after the antihelminthic treatment. So in case of Sarginata, suckers and the hooklets, the four suckers will be present, but there is no hooklets and the rostrum. In the solium, you can see the rostrum with the hooklets. Tinea specific antigen detection in the stool, coproantigen by ELISA. Advantageous, it is more sensitive than the stool examination and can detect the carriers. Limitation, it cannot differentiate between the Sarginata and solium. Antibody detection in the serum by precipitation, agglutination, complement fixation test and by ELISA. Limitation, it cannot differentiate between the present and past infection. Recently, there is a immunoblot is developed for Tinea solium specific antibodies and which is 95% sensitive and 100% specific. Molecular methods like DNA probe and PCR can be used. Laboratory diagnosis of cysticercosis, mainly by radiodiagnosis, imagining CT and MRI scan. It can detect the hypodense area of cysticerci and hyperdense eccentric area inside the vesicle. That is scolex. So you can see in this picture, there is a hypodense area of circle which is showing in the arrows. Antigen detection using ELISA by using the monoclonal Tinea solium antibodies. Antigen disappears following the treatment, hence can be used for the monitoring of the treatment for the prognosis. Histopathology, cysticerci can be detected in the muscle, eyes, subcutaneous tissues by biopsy following the surgical removal or FNC of the cyst followed by microscopic demonstration of the parasite. So you can see in the picture, this is the picture of Cysticercus cellulosa in the biopsy from the brain showing in a H&E stain. Other tests which include ocular cysticercosis can be diagnosed by using by doing ophthalmoscopy. Eosinophilia is also one of the features that can be seen in the early stage of cysticercosis. Del Brutto diagnostic criteria for human cysticercosis. It is proposed for the diagnosis of neurocysticercosis in endemic countries. It is based on the clinical, imagining, immunological, and epidemiology. It includes absolute criteria, major criteria, minor criteria, and epidemiologic criteria. So, absolute criteria, which include demonstration of cysticercosis by histologic or microscopic examination and also visualization of the parasite by fundoscopy and neurological demonstration of the lesion. That is the absolute criteria. Major criteria includes neuroradiologic lesions suggestive of neurocysticercosis and demonstration of antibody and also resolution of the intracranial cystic lesion spontaneously or after the therapy. Minor criteria, which includes lesions compatible with the neurocystic sarcosis detected by neuroimaging and clinical manifestation which suggests the neurocystic sarcosis, demonstration of antibodies, and also evidence of cystic sarcosis outside the CNS, that is cigar-shaped soft tissue calcification. Epidemiologic criteria is the residing in endemic areas or frequent history of travel to the endemic areas or household contact with the infection. These are the some of the criteria. Those are used for the diagnosis of cysticercosis in case of endemic areas. Coming to the treatment, intestinal tiniasis is treated by praziquantel, which is the drug of choice. Single dose 10 mg per kg is highly effective. Niclosamide 2 gram is also effective but is not widely available. For cysticercosis, for brain parenchymal lesion, albendazole 15 mg per kg per day for 8 to 28 days. Praziquantel 50 to 100 mg per kg daily in 3 divided doses for 15 to 30 days. Longer course are often needed in the patients with multiple subarachnoid cysticercosis. Surgery, open craniotomy to remove the cysticercosis is rarely required nowadays. Surgery is indicated for ocular ventricular lesions because of the drugs that provoke the irreversible inflammatory damage. Prevention, intestinal tiniasis can be prevented by adequate cooking of the beef or pork, refrigeration or salting for longer periods or freezing at minus 10 degrees Celsius for 9 days. Effective fecal disposal to prevent the infection to the cattle and pigs. Cysticercosis can be prevented by good personal hygiene to prevent the autoinfection with the eggs, effective fecal disposal to prevent the contamination of the food and water with the eggs, treatment and prevention of human intestinal infections. Thank you. Any doubts?